They define the highest risk patients, including those receiving chemotherapy or those who very recently received chemo, those receiving extensive radiotherapy, those who had stem cell transplantation within the previous 6 months, or those who remained on immunosuppression, and patients with certain hematologic malignancies even in the absence of active therapy. As a hematologist who cares for transplant patients, this slide represents most of the people I care for, with the exception of a few long-term survivors. Recommendations were made for testing, including prior to starting therapy if feasible. It was also recommended that communications with other professionals and with patients be done remotely whenever possible, and recommended that virtual visits be made for toxicity evaluation, dose adjustment, and supportive care recommendations also whenever possible. They recommended that conversations about the benefits and risks of therapy be discussed with all patients in the setting of the pandemic, and recommended a risk-adjusted approach. Importantly, it was noted that cancer patients who developed a fever needed a mechanism to be evaluated outside of oncology clinics in case that fever was a sign of COVID-19, but we were also very cognizant of not sending our patients to emergency departments whenever possible in order to avoid potential exposure in case that fever was due to one of these myriad other possibilities for a fever in a cancer patient. And lastly, priorities were assigned based on patient condition and disease stability to help guide making treatment decisions. So with this information, we knew what we needed to do. We had clear guidelines for how to approach cancer patients based on disease, condition, and where they were in their cancer journey. We just needed to make it happen. Minor detail. In February, 0.01% of our patient visits were via telehealth, or at least what we call telehealth. So why did it take a global pandemic to change the way we approach patient visits? Telehealth was established as a Medicare benefit prior to the pandemic as part of the Social Security Act, but it was incredibly restrictive. Telehealth, which is synchronous, was required to use interactive audio and video telecommunications, and asynchronous contact was only permitted to federal demonstration projects in Alaska and Hawaii. Telehealth was restricted based on the geographic location of the patient, the originating site of the patient. For example, a visit was not covered if the patient was located in their home, but was covered if they went to a local physician's office, for example. It was also based on the eligibility of the physician or the provider providing the service, where the provider was located, and the services provided. The list was also limited to specific HCPCS or CPC codes. In order for telehealth to be a viable option, there needed to be changes in terms of restrictions, reimbursement, and licensure. On January 31st, Alice Azar signed a public health emergency declaration that allowed the ball to start rolling on subsequent steps, and Mr. Trump signed a national emergency declaration on March 13th that was retroactive to March 1st. The Coronavirus Preparedness and Response Supplemental Appropriations Act allowed for the waiver of Medicare limitations on telehealth services that were delivered by qualified providers during the emergency period, and it also permitted telehealth via telephone, but essentially limiting it to communication that could be done via a smartphone, at least early on in the pandemic. Fairly shortly on its heels, the Coronavirus Aid, Relief, and Economic Security Act waived state licensure requirements for practitioners and waived the pre-existing relationship requirements. So previous to COVID, telehealth could only be done if there was a previous therapeutic relationship established between a provider and a patient. This act waived that requirement, which paved the way for new patient appointments to be done by telehealth. And then starting on March 6th, Medicare started to reimburse professional services that were furnished to beneficiaries in all areas of the country, in all settings, rural, urban, didn't matter. And there was no longer a requirement that a patient be present at any kind of originating site. So what this meant was that patients could now be seen in the safety of their home, no matter where in the country they were located. Telehealth visits were now considered the same as an in-person visit and reimbursed at the same rate. And while virtual check-ins or short patient-initiated communications with a healthcare provider were a Medicare benefit prior to the pandemic, there was limited availability for reimbursement. In 2020, the use of e-visits or non-face-to-face patient-initiated communications through an online patient portal was expanded. As of this spring, virtual check-ins became available through either synchronous or asynchronous technologies and via multiple forms of communication, which included telephone, audio, video, secure text messaging, email, or patient portals. All of these were now permitted. With e-visits, patients needed to generate the initial inquiry, and asynchronous communications could then occur over a 7-day period. There needed to be documentation that patients verbally consented to the service, but these were another option for patients to continue to maintain close contact with their provider's offices. So this slide details changes for us that occurred over the first 2 days of April. While we did see a sharp reduction in the number of total encounters health system-wide, we also saw sharp increases in the number of telehealth encounters from our February totals, which, given that it was 4 visits, was not all that hard. But only 20% of the telehealth visits on April 1st were video visits. However, on that one day, it equaled the number of telehealth visits that were performed, or video visits that were performed in the previous week. In the last 2 days of March, there were 2,200 video visits that were scheduled, and 15% of those visits were new patient visits. By April 2nd, we had over 600 laptops enabled for telehealth, with over 200 cameras deployed. Which kind of leads us to talking about platforms and just how we're going to conduct these visits. Because this was previously fairly restricted by HIPAA and the Office for Civil Rights. And with the emergency declaration, restrictions on the platforms that we used were also relaxed. And it was determined that the Office of Civil Rights would not impose penalties against providers for the lack of a business associate agreement with video communication vendors or any other non-compliance with HIPAA rules relating to the third-phase provision of telehealth during the public health emergency. So essentially, if you were trying to do the right thing, then you had some latitude to do the right thing. Providers commonly used included Skype for Business, Microsoft Teams, UpDocs, VC, Zoom for Healthcare, Docsimi, and Google G Suite Hangouts, among others. At OSU, we gave patients and providers the option to use video visits through Epic, our EMR vendor, or through a third-party platform, most commonly UpDocs. We created several new visit types for telehealth visits, and our patient access specialists would ask patients about whether they had access to a smartphone or a computer with a camera in order to conduct a video visit, whether they had a mind chart in order to determine what kind of video visit to schedule. Visit types for physicians and APPs were released first, followed very shortly by visit types for other clinical providers, including physical, occupational, and speech therapists, social workers, and other ancillary providers. Our IT team worked quickly and efficiently, and we can't say enough about the work that they did to deploy web cameras and software around the gyms and in our satellite clinics around Columbus. So providers who continue to see patients in their clinics could also integrate telehealth into their workflows. Software was also pushed to university-owned laptops, and upon deciding that UpDocs would be a third-party vendor of choice, teams worked quickly to make sure that all of the providers, followed by other clinical staff, had accounts in order to do visits. Our teams developed educational tip sheets for both patients and providers. Haiku and Canto are Epic's mobile offerings for iPhone and iPads respectively, but these are only available on iOS devices, so it could only be done by providers who had Apple smartphones or iPads. Because it is only available on iOS devices, my group, our Division of Hematology at Ohio State, worked to purchase iPads for every clinical member of the division before the university shut down our discretionary spending. By doing that, we ensured that every clinician in our group could conduct a video visit with a patient, no matter where the provider was. Between the availability of UpDocs within a compatible web browser and making sure that all clinicians in our group had access to an iOS-compatible device for iHIP integrated visits, we also ensured that if a patient had an exposure, or if a provider had an exposure and could not see patients in clinic, he or she could still see patients from home as long as they were feeling well. Our patient access specialist did a wonderful job of developing workflows across the gyms, as well as all of the university hospitals, to make sure all patients had access to telehealth appointments, either by video or by phone. All departments and divisions were asked to identify patients whose visits could not be completed by the telemedicine. And in oncology, this is a fairly lengthy group of patients. It includes patients who are getting active chemotherapy, those who are receiving infusion therapy, such as IVIG or eculizumab, patients who are needing blood transfusions, and patients who had recently undergone autologous or allogeneic stem cell transplantation or other cellular therapy, or those who are undergoing workup to start treatment. So this is how we kind of did our workflow to get patients seen appropriately. On the day of the visit, patients would be contacted by registration staff who would advise patients on how to connect with their appointment. If they were connecting to MyChart, patients could click on the video visit icon within MyChart up to 15 minutes before the start of their video. If they were joining by a third-party platform, patients would be advised that the provider would send them a link by email or text at the time of the visit. For many of the James clinics, our nurses would call patients prior to the start of their appointment to do a medication reconciliation and a nursing assessment, and then remind the patient of how the provider would be contacting them and make sure that they have the appropriate contact information, particularly if we were contacting a patient via UpDocs and needed to know appropriate cell phone number or an email address. This is a view of what a patient would see in MyChart with an upcoming visit. They have the option to register themselves by e-check-in, and it's clearly stated on the appointment, many places, whether it's a video or a telephone visit, and there is a reminder in all caps not to go to their clinic. If patients would then click on details, this is what they would see. They would have the option here to confirm the visit, letting staff know that they didn't need a reminder call. They would also have the opportunity to check in by completing their registration questions ahead of time. And they had an option to test their hardware ahead of time to make sure that the webcam and microphone are functioning correctly. Although I can tell you, if you test your hardware ahead of time, it doesn't necessarily always tell you it's going to work when you want it to. They also had the option to add the appointments to their calendar. And there was another reminder again on this page not to go to the clinic, as well as some advice for best practices for how to successfully conduct a video visit. Initially, we institutionally recommended that providers try to conduct visits through MyChart when available, with a secondary preference for UpDocs, as it's HIPAA compliant and easy for both patients and providers to use, with WebEx and Skype next on the list because we had existing security agreements with them. However, the MyChart offering had some limitations in terms of timing of appointments and when we could log on relative to the appointment schedule. And it's also not quite as easy for patients to use as UpDocs, so free markets prevail. And over time, the proportion of UpDocs visits has increased a lot due to its use of ease of use and due to improvements in clinic workflow. We're just using one platform that's nearly universally available to patients as opposed to switching back and forth the platforms and figuring out where you're at any given time. There is a bit of a learning curve with everything though, and even though UpDocs is super easy to use, it did take our providers a little bit to consistently understand that they cannot use Internet Explorer with UpDocs, despite the fact that it's pinned to the bottom of everyone's screens in clinic. And it's sort of funny because even last week I had an UpDocs visit with a patient who took a little bit to log on, and he had forgotten about the browser requirements, but luckily he was someone who was very tech savvy and was able to get everything switched over pretty quickly. For people who are not tech savvy, even something like a browser requirement can be a fairly major irritant. So this is what patients use on UpDocs. The video is clear, and there are simple icons that allow them to mute themselves and unmute themselves, turn the video on and off, and switch cameras if they're on their phone, which is really convenient if there's some sort of physical exam finding that I need to see. They can, use the camera to switch things around, and you actually do have the ability to do a better physical exam with just a video than you might think you would once you have a little bit of training and experience. In a normal encounter, a patient would see an image of themselves in the lower right corner. Here you see my fuzzy cat, because my daughter was helping me out with getting pictures. This is my daughter Katie and her cat Benedict, who graciously agreed to help me get screenshots for the talk. But this is what I see on my end when I'm using an UpDocs encounter. And the controls similarly are really easy to use. And then the switch icon comes in handy when you're talking with a patient who wants to meet your dog, which has happened to me on more than one occasion. So if you remember the slide from earlier, where in February, out of our 55,000 check-in visits, 4 of them were video. By April, our total appointment volume was down, which was expected. But of the nearly 42,500 visits that were checked in, over 5,000 each were video or telephone. This month, while we were kind of new to everything, video visits just slightly outpaced telephone visits. By May, our providers were increasingly comfortable with video visits as opposed to using telephone visits, and we were also receiving some administrative pressure to use video visits as opposed to telephone visits. And these are being conducted at this point at more than twice as often as telephone visits. By September, our outpatient clinic volumes were back up to our pre-COVID numbers. And while face-to-face visits were back up over 93% at that point, there is still a significant number of video visits being conducted compared to normal times. But the ratio of video to telephone visits was relatively preserved, with video visits being done at a little bit more than a 2-to-1 proportion. So how did we do? Importantly, did we meet patients' expectations through our transition to telehealth? Based on patient satisfaction numbers through August, it appears that we did do a pretty good job. These are patient satisfaction numbers from September of last year through August of 2020 for the outpatient hematology clinic for WSU. And I do suspect, based on the number of patients who I talked with in April and May, who were more concerned with how we were doing and how we were holding up in the pandemic than about how they were doing, I do suspect that these numbers may reflect a little bit of goodwill from our patients. But even with that, our mean patient satisfaction score didn't waver. Numerically, it even went up a little bit in April and May compared to our usual mean. And we did a good job of delivering the care that patients were expecting to receive during the pandemic, even as we were all running together as we went. I think part of it was a good job of managing expectations for our patients as well. But regardless, they were pretty happy with what we were able to offer them. In addition to meeting patient expectations, did we keep them safe? So I'll use my 10-year-old world as an example. I'm a transplanter. I take care of patients undergoing Oncologist and allogeneic stem cell transplants and other forms of adaptive cell therapy. With doing that, we wipe out pretty much their ability to respond to most pathogens, viruses, funguses, bacteria. So these are highly immunocompromised group of patients. And we were nervous. In March and April, we were very scared for what this would mean for our population. We've seen H1N1 kind of decimate our transplant patient population, and we were very nervous that something like this was going to happen again. We have a federal mandate to report all allogeneic transplant outcomes, and over 75% of autologous transplants and cell therapies are voluntarily reported to the Center for International Blood and Marrow Transplant Research. The CIBMTR very early on in the pandemic mobilized quickly to develop a form allowing for data on COVID and transplant patients to be easily collected. There are over 550,000 patients who are currently being followed in the registry. Of those patients, as of October 25th, there have been 641 reported COVID-19 infections. Unfortunately, approximately 20% of infections did result in death, confirming our fears that if infected, our patients do not do well. However, with 0.1% of the population in the registry developing an infection, it is very encouraging that the rate of infection in this population is much lower than the 3% currently reported in the United States. Our patients are well acquainted with the need for masks, good hand hygiene, and avoiding sick people. So I believe that the behaviors that are ingrained in transplant patients are going a long way to keeping them safe. But I also believe that our efforts to keep them safe at home and away from the hospital contributed as well. In the United States, according to CMS Administrator Verma, 13,000 individuals received telehealth services per week before the start of the pandemic. In the last week of April, 1.7 million people received telehealth services across the United States, including 22% of rural Medicare beneficiaries and 30% of urban beneficiaries. For now, regulatory restrictions for telehealth have been lifted. There's reimbursement parity, and we have high-quality platforms that allow for a good patient experience, maintaining patient satisfaction and safety. But there are still barriers to universal uptake of telehealth. Not all patients have access to smartphones or computers with video with which to conduct video visits, and often these are the patients who could benefit most from having a mechanism to make contact with their physician without taking a day off of work or spending money on gasoline. Broadband coverage in the United States is most heavily concentrated in urban areas, with less reliable concentration in more rural areas, and patients are responsible for learning to use the platforms on their own. Many of our older patients will have their children or grandchildren assist with video visits, but it can be problematic when more tech-savvy friends or relatives are not available. According to Administrator Verma, Telehealth will never replace the gold standard in-person care, which I think is an accurate statement. However, telehealth services is an additional access point for patients, providing convenient care from their doctor and healthcare team, and leveraging innovative technologies that can improve health outcomes and reduce overall healthcare spending. CMS is currently reviewing changes made during the pandemic and determining which should be made permanent, looking at the impact that these changes have had on access to care, health outcomes, Medicare spending, and impact on healthcare delivery. We can see many potential uses for telehealth, and among those, one of the uses I hear most frequently from my colleagues is use for second opinions, as well as urgent care triage, post-hospitalization follow-up appointments in order to try to reduce readmission rates. It can be a great adjunct for psychosocial oncology, survivorship visits, and increased access for rural patients and patients who may have transportation issues. So what next? How do we move forward from here? And the answer is, it really depends. And what it depends on has a lot to do with the maintenance of currently relaxed telehealth restrictions, and how much of those restrictions are going to be put back into place after the pandemic. It's expected that telephone visits at some point will no longer be reimbursed at similar rates as a face-to-face visit, but continued use of video visits will be dependent on continued reimbursement parity. When we use a video visit, we are losing hospital fees, so we do, as an organization, get a little bit less revenue from the video visits, but if we can demonstrate that we are providing greater quality of care at reduced cost to the patients, this is something that hopefully won't matter as much, but we do have to demonstrate that we're providing excellent quality of care while meeting the IOM quality standards. Out-of-state licensing reciprocity. So patients, particularly in subspecialized fields like oncology, or for providers who live and work near the border of a state, licensing flexibility will go a long way to informing how we can use telehealth. One can imagine a scenario where a patient can get a second opinion from a leading expert from their disease via telehealth if states develop permanent mechanisms for licensing reciprocity for telehealth, or a situation where a subspecialist in one state can assist a general oncologist in another state, keeping the patient close to home and reducing the cost of care for that patient, both in terms of monetary costs and in terms of cost of time. Once we have a better idea of what the rules surrounding telehealth will be moving forward, we'll have a great opportunity to bring care to the patient rather than making the patient come to us. And with that, I'd like to thank you for your attention. And like I said, I'd like to leave a healthy amount of time for questions in case anyone has questions for me. And again, throwing Rob under the bus for Rob.
So thank you, Dr. Jaglowski. I think it's important to realize how much stress our frontline care providers, like Dr. Jaglowski, were under to protect their patients. And again, as I mentioned at the outset, Dr. Jaglowski had kind of a dual role, helping, obviously taking care of her patients that are, quite frankly, some of the most immune compromised and the sickest of the sick, and how do we keep them safe and out of the hospital? And that was kind of the goal for the entirety of the James Cancer Hospital, but I think very specific to the patient population that she treats, in addition to her other hat that she wears as being a clinical informatics lead and helping with the rollout of telehealth, and lots and lots of questions about workflow and how do we do this, and how do we make sure that we're able to connect with our patients? How do nurses connect before the doctor gets on? How do we handle those patients who are not so technologically savvy, as was pointed out. And then lots of stuff around payment and billing. And my patient lives in Kentucky. Can I talk to them? And Dr. Jaglowski pointed out to all of that. So it's remarkable the amount of work that went into this in such a short amount of time, and the questions continue. So thank you, Sam, for what you do for our patients. There are a couple questions in here. So from my old friend Liz Curtis, how does your visit on time percentage compare before COVID versus telehealth?
That is a fantastic question. It's a little bit challenging to answer, in part because with my clinic in particular, we were also making some adjustments to go from doing primarily split shared visits to primarily independent visits, so we wouldn't be exposing patients to as many people. And it turns out doing it that way was much more efficient. I think the other reason it's a little bit challenging to answer was because I mentioned earlier in the slide, like my patient population was one where we really couldn't get more than half of the patients switched over to telehealth. And we didn't do the best of jobs of organizing it. So like we had telehealth visits at the beginning or the end of the day, they were just sort of interspersed throughout the day. Which was actually very challenging for our nurses because they would have to go from rooming a patient in person to making a phone call to do a nursing assessment. And I think if this comes to pass, where this is something where we can do telehealth more like a permanent structure, a permanent part of our clinic, I think that's going to be really important for us to be cognizant of. Is, we're going to use a batch of telehealth visits, batch of in-person visits, which going back and forth is not remotely efficient. I think there's a good chance it would probably be much better because it is sort of hard to, just sit and chat over a video, and that's where I tend to come in. Like, if I'm going to run late in the day, it's because I've been sitting and chatting with people. That being said, many of our patients were also very lonely at the beginning of the pandemic. And so we found that they wanted to talk once they got on the phone. And we also didn't do a good job at all of getting them off the phone because we knew they were lonely and just needed to talk to someone. And so I feel like the potential is there for it to be more efficient and have us be more on time. I think the way that we executed it early on didn't really allow that to happen. So I don't know if I answered your question really well. And I think probably a person who's like not my clinic may have answered the question differently because we like talking to patients. So that's part of where we run into trouble is we enjoy the interaction and we just kind of let it happen as it did, but that turned out to be not really efficient.
Liz, I think the data bore out, it was hard to determine the on-time starts, but we can definitely tell you that the cancellations went way down. So that was a big difference. And we've got another question, Sam. From your perspective, what was the most ideal way to provide patient education in the virtual health environment?
Oh, that's also a
great
question. Yeah, because that's for cancer care, for us in particular, we do a lot of patient education. And where this ran into problems with us in particular is when we're doing a transplant, we have our nurses do this whole long education session. It's like an hour PowerPoint of, what to expect during your transplant, what to expect when you go home. And then once the patients have been in the hospital, they finish their transplant, our nurses do an education session with the caregivers for, okay, here's what you expect when you go home. Here's how you take care of one. Here's how we're doing this stuff. Well, early on in the pandemic, we weren't having any visitors, like no one. So we couldn't have caregivers come in and get this patient education, which our nurses did a fantastic job of being really flexible and figuring out how they could do things, like through WebEx or other mechanisms, how they could share the information. with caregivers and demonstrate, how to take care of a line, how to do dressing changes, things like that. So kind of WebEx initially. During all this institutionally, we switched over from using primarily WebEx to Microsoft Teams. So this has been a little bit of a shift, but a lot of this education can take place over Microsoft Teams. We do have caregivers coming back in the building now, so they're able to do the in-person teaching. But if we get to a point where, as the numbers in Ohio seem to be getting a little bit worse, if we ever have to go to a situation where we shut down on inpatient visitations again, they've got this whole process worked out by Microsoft Teams. I wish, this is like on my wish list for UpDocs, that I could share my screen with it. I would love to be able to show patients like what their radiology looks like. Like right now, I'm using the flip camera, so I can show people their PET scans when I'm doing a video visit, which isn't truly all that efficient. I would love to be able to do some stuff like that. And Rob, let me know if I'm just missing out and I can do it. But, yeah, we can send email links. If their ABS is still available in the EMR once we finish off, once we close out on the patient visit. So we can put links in their ABS, we can put patient education in there, and they can get all that great information. So I feel like we've been able to be creative and come up with ways to make sure that patients are still getting the information they need and access to the information they need.
Did you push anything like through the portal? So did you use like HealthWise or any of that information and push through MyChart or mostly?
Some, a little bit, yeah, we've done it some that way. I guess, HealthWise is great, but, we're so sub-specialized that the content isn't like really all, but, we have pushed sort of our homemade stuff through. Chemo information for sure. And definitely push that through. And then our pharmacists have been really engaged too in calling patients and making sure that, before we do chemo starts, that they're, educated and are doing a lot of that stuff via phone that, we would have done in original or, in normal times.
Awesome. Any other questions for Dr. Jaglowski? So thanks everyone who participated. I see a lot of familiar names, so that's great. Some that don't, like Sarah Vetter out there. Good to see you on there. If the keynote for the afternoon, the last session for the afternoon is starting in about 7 minutes, and that's on the original Zoom. And again, I want to thank Dr. Jaglowski for talking. I have one quick board duty. I want to make sure that we recognize that UpDocs, who Dr. Jaglowski mentioned, is actually sponsored a part of this conference, which is great. And I think from a personal experience that we were, they saved our bacon in a lot of ways. So they're a great vendor. And with that, I will let everyone go. Thank you very much.